ways by asking them their name, birthday, and any allergies, and okay, what are you checking that armband with? The MAR. Should you ever go into a patient's room to administer medication without a MAR? No. Right. Do you think, luckily at Northeast, we get to wheel the little card in. But those of you at Rowan have to have a paper MAR with you when you go into the patient's room. Do you think I'm going to let you go all the way in there without that MAR? Did you forget it? Do you think I'm going to let you go in there without it?
Yeah.
Is it my responsibility? No. Who's administering the medication? You are. It is your responsibility. I will let you go all the way to the bedside. Okay? And then what do you think I'm going to do? I'm going to say, hold on just a second. I'm going to get the MAR and I'll administer the medication. So there should be no reason why you should not realize that you've got to take that with you, because that is another way that you're going to identify your patient with the MAR and their ID band. Okay? If you forget to identify your patient, do you think that I'm going to let you administer the medication? So this is how we'll handle it. We'll let you go all the way into the room with your meds. And you say here. And what do you think Miss Walker's going to do? Excuse me, can I have your medications? I'm not going to embarrass you in front of the patient, but I'll say, I'll let you go all the way to that situation before I say to you, let me have the meds. Okay? Because it is your responsibility. I have told every one of you that you are to check your 5 rights and that you are to identify your patient 2 ways. Right? So there is a mutual understanding here, correct? That everybody knows that this is what's required of you. So there should, yeah, you're going to be nervous. Yeah. And maybe the first week, when you go in there, and I say to you, do you have everything you need? Read my lips. If I say to you, or any instructor says to you, do you have everything you need? You don't. You don't have, you are missing something. And what do I want to do? I want you to find it. Right? Because I can tell you, you think, oh my gosh, I forgot this. You'll never forget it again. Right? So I want you, and that's the first week. Okay? We'll do that to you. Do you have everything you need? And if you say, hear those words, that you are missing something. Now the second week, if I had to tell you the week before, I'm not going to let it. I'm not going to change it. I'm going to let you go all the way in. I had a student one time, we were given IV push medication, walked right into the room without the MAR, did not identify the patient, cleaned the port with alcohol, which is good, connected the syringe, and looked at me and said, can I push? What was my response? No. Just a second. I went out to get the MAR, brought the MAR in, identified the patient correctly, did all my checks, and then proceeded to give the medication. Now, whose fault was that? It's my fault. Didn't you know that? It's my fault. That's what the student said. It's your fault that I forgot this. That is not my fault. That is your responsibility. If you learn to do that every time, there should never be a medication error, right? Never be a medication error. If you follow the steps of medication administration, you have to do it. Question, Jason?
We're commenting.
Your comment? Would you like to share?
We're just betting if you went off or not.
We're just wondering what your face was like and how you decided.
What shade of red would you turn?
Yeah. Well, I was very calm in the patient's room.
Well, I mean, I bet that, yeah.
Very calm in the patient's room. But guys, I can be a hidey hole sometimes. But I'm telling you, I'm trying to teach you how to be a safe nurse. Make a mistake with me. Make a mistake with me. With me right there over you. Making sure that you do it. Because I guarantee you, when you make that mistake, you'll never do it again. Good. Okay, and you're going to keep that patient safe. Right. Exactly. All right. I want to just go over some, we talked about the routes, but I want to go through each one of the routes again and telling you the different things that you need to do when you have the PO med, okay, that you'll see, or all the medications. Of course, the route that we will give most commonly is going to be PO, right? One of the first things that you need to make sure before you ever administer anything PO is what?
If they can eat.
Make sure they're not in PO and make sure they can what? Swallow. Okay? Don't give people something that's been aspirating into their lungs. So you want to make sure. And wouldn't you have already done that on your assessment? Because you assess for the gag reflex and you had them swallow for you to make sure that it looked, everything was good. So make sure that they can swallow and make sure that they're not in PO. I put up here for you, and I don't know if you can really see it that well here. Do I need to flip a light? Better? Okay. This is a peel cutter. We have lots of them in the lab, so you can get the experience of actually cutting peels, because there are going to be times that your order says a half of a peel, and you're going to have to cut this. Now, it has a razor blade right there, okay? One of the biggest things I want you to do when you get one of these is make sure that it's clean, okay? Sometimes nurses use them over and over again, and a little bit of the residue from all the medications is still on there. So if I'm going to have to cut a peel, I want my patient just to get the peel they have, not everybody else down the road, a little sediment of that. So I want to make sure that it's good and clean, and usually after I give my medicine, or before I give I make sure it's clean, but I also do it after it for the next person coming on. Okay? And that's just a courtesy thing to make sure that it's good and clean and you got everything off. So I just take an alcohol prep and just clean all around here and make sure that there's nothing up there. If you clean that blade, please be careful. Okay? Just please be careful, because it is a razor blade and it will cut. So, and all you need to do is, the majority of the peels that you cut are scored. Do you know what I mean when I say the word scored? Okay? It's got a little line in the middle, and it's designed to be cut, because there's going to be a time that I have to give somebody a half a peel. So if it's scored, and all you do is slide it into this little V here, and put the scored thing in the middle. So this should be right, the scored should be right there. And then when you shut that, the razor blade cuts it in half. Okay? When you are, and we'll go over this later, I do not want a lot of hand, or any hands touching these peels. So after you've cut it, you need to have the cup that we're going to put the medication in and slide it in there. So you're not picking it up like we would at home. Wouldn't we do that at home? We just pick it up and put it out. In the hospital setting, we don't do that. We just slide the little cup there and pour it into our medication cup, okay? And you're going to practice doing this on Tuesday, Wednesday, okay? What pills do you do not cut? Enteric coated. Right. Enteric coated, do not cut them. Can they be crushed? No. Enteric coated pills cannot be crushed as well. Now, is there a difference between halving a tablet and crushing a tablet? Yes. There is a difference. Do you know how to crush tablets? There's several different ways, and different ways that we have at the facilities that you're, depending on what you're in. I do not have a picture of that for you, but some places have a little container about this big, and it has a screw on top. And you just stick the pills in there and screw the top down, and when you screw it down, it crushes the pills. Okay? Another way they do it is they have a little machine. It's not a machine. It's just a little, I don't even know what it really looks like. Is it a machine?
It is a machine.
It's like a little handle. What you do, right, what you do is you get the baggies, and you put all the pills in the baggies, and then you slide them down into this little groove thing.
With a flat plate over here.
Go, would you like to describe this? Because I am not good at describing this.
Do it,
It's
Joey.
got a handle, and whenever you lift the handle up, it pulls the plate back. And you put the pill in between, and you slap the handle up
And you
and down.
take your frustrations out.
Right.
Just like that. And it crushes the pills for you. Okay? So when your patients have difficulty swallowing and they're on like thickened foods, we need to crush their medication and give it to them in applesauce. Or give it to them something that has consistency for them so they can actually swallow it. So you can actually crush your pills, get some applesauce, pour the pills in there, and stir it up, and then feed the patient the medication that way. Okay?
So that's a nursing judgment. You don't have to have a doctor's order to crush
No.
pills there.
No, you do not have to have a nursing judge, you don't have to have a doctor's orders, but if you have anybody having difficulty swallowing pills, I just crush them. And then I talk to the patient and say, I saw you had a little trouble swallowing. Do you think you can swallow these pills? Or I'll be glad to crush them for you and put them in some applesauce. Okay, so that is a nursing judgment call.
When you're halving, if you're getting half the pill, are you disposing of this other half? Or what are you doing?
Right, it needs to be disposed down the sink. Okay, and I'm glad you brought that up because if it's not a controlled substance, you don't have to have anybody watch you get rid of that other half.
So even if they're getting a half every morning, every time you split it, you dispose of half.
I do. Because I don't know, and it's not that I don't trust people, and I see where you're going, because if you are just giving a half a pill, and that you're going to give that half a pill at a later time, you know what's in there, but I don't know the nurse before what she put in there. So I don't feel comfortable getting a wrapper with a half a pill in it, because I don't know exactly what's in there. So I discard of it, and I'm sorry it's costly to the patient a little bit, but it's more, I feel better that I know without a shadow of a doubt that I gave that patient the right medication rather than having something that's been sitting in there for hours. Does that make sense?
You have patients getting half a pill. Can you order from the pharmacy already split?
Because that way it'll be where I can't see the wrapper and see what's in it. You see what I'm saying? I want to make sure that when I give a pill that I open it and I've done all my checks with that in there. Okay? So I would prefer not to have it like that.
So on when the 3 checks of check the drug, when we do it first, we get out of the drawer, whatever, and then check it when we're preparing it. But then if we're gonna crush it, we want them to just check it in the room, then we ask them to go back to crush it. So do we check it,
You can take all that stuff
take
with
a little
you.
pack, the little,
Yeah.
and then check the little papers with them or something, or punch out things. When the back of the room needs to be go over it again, you sit in the room with the patient. check.
Right, that's gonna be your 3rd check. So yes, you have had done your checks and you cut it or half it. I do it in the patient's room when I'm doing all my scans and everything. The crushing may be a little different as I go into the patient's room and scan everything, identify them, and scan the meds. Then I may have to go back out and crush them. Is that what you're asking me?
Yeah, because that just, since you're
Yeah.
in the room again with them, it just like,
Right, yeah. And that is another, depending on if you were able to actually take that crusher with you in the room, then I just take it in there and crush in there. You know, it's just one of those things you're gonna have to figure out. If my patient's on isolation, no, I would not take that machine in there. But if they're not on isolation, I'd take it in there. If they don't like loud noises because it's very loud, no, I'm not gonna take it in there. So there's all kinds of things that may contribute to you making that nursing judgment call, when do I actually. But if you've got to still do your checks like you're supposed to. That makes sense? Clear as water or clear as mud?
well, I just say if you check it in the room and then they say, yeah, would you please crush it, then you leave the room with the medicine again. What if somebody picks you up and you made a mistake out there and the crusher, if the crusher can't go in the room?
Well, as long as you've done all your 3 checks and you go straight to the crusher, crush them, and go right back, then you're good. Yeah, you're good. I'm trying to think if there's anything else I need to say about PO pills. Those are the kind of things that I wish I could tell you every time this is the way you're going to do it. Okay? But I can't. Every situation is different. So,
When pills that cannot be crushed or cleared or anything else, and if they can't swallow, then do they come in liquid form or anything like
that
that?
would be my first thing to call pharmacy and say, is there any way I can get this medication liquid? If they can't, then I will call the physician and say, my patient can't swallow. You have ordered this. I can't crush this. Give me another order. Can I either DC this or can you give me another order where I can? And most of the medications now, they are doing liquid form. Okay, which has been a blessing. And a lot of times it is our responsibility to see that medicine comes in liquid form. So, yeah, right. All right.
So if the order is for a pill, but they can't use it and they need liquid, do you have to get a new order for liquid form? Okay.
Yeah, because remember, what are the things that you got to have in order to make it right? Doctors, yeah. You got to have the right dose because liquid may come right med, right dose, right time, right route, right frequency. So if you see in liquids, a lot of times it comes in different strengths. So, yeah. All right. We'll practice on this Tuesday as well. Liquid form. Let me just tell you, when you have a liquid form of PO medication, how many of you have taken cough medicine? Everybody, right? What do you do when you pour it into a cup? You pour it in a cup. Do y'all really do that?
Turn the bottom up and drink it.
I thought that's for sure what y'all would do. Right. Well, one of the first things I want to say about it is when you put that syrup in that cup, ever how you draw it up, and you take it back this way, what happened? It just drips all down the little side of it, and you can't really tell what it is. It gets sticky everywhere and that kind of good stuff, right? Well, we're not going to do that in the hospital. what we're gonna do when we get the liquid bottle that we use, it's going to have a label on it, right? You're gonna put that label in the palm of your hand, okay? Palm of your hand, because when I pour this way and I put it back up, if it leaks down, it's not getting on the label. I have to know on the label what it is with all the correct information. If I keep pouring it and the sticky stuff keeps running down the label, I'm not going to be able to see what kind of meds it is. Okay, so you want to put the label to the palm of your hand. Then you can get your medicine cup, and yes, you can pour it like this. And you can actually see his label is in the palm of his hand. Okay, you can either put it on the table, but you've got to make sure that you are at eye length or eye level. Okay, every one of you are going to have those cups, and yeah, you can, say you can pour it like this, but this is the way you're going to be. You're going to be so nervous that you're going to spill it everywhere. So put it on a table and just get down to eye level when you're pouring it. And you want to make sure that the base of the meniscus is at the actual dose that you're going to be given. Okay? You know what I mean when I say the meniscus? It's that there's a little curve thing, and it's like right here. That's what you need to make sure it's level. Okay? I think you probably already knew that, but now I'm just reinforcing it. All right. All right, we didn't talk about the other routes so much, so I'm going to swoof by these real quick. Sublingual is another medication or another route that you're going to use as you administer medication. Sublingual means what? Under the tongue. Is it supposed to be swallowed? No. It is supposed to be absorbed under the tongue. So you just lift their tongue up, put the pill in there, and put their tongue back down. Okay? What type of medication do you usually see given this way? Nitroglycerin. How do you administer, you administer nitroglycerin is mostly because why? Chest pain. This is a medication that you're going to give lots and lots and lots. There are certain things that you need to realize about nitroglycerin. And I think y'all did your little at the med cart thing. So that's going to be some things that I may ask you at some point in time in your life. When you give a patient, they say they have chest pain, they have nitroglycerin ordered, you go through your checks just like everything, like you've always done it, identify them, you put it under their tongue. How frequently can I give this medication? Every 5 minutes for how many times? 3. Okay? What happens if that third one don't work? Call a code. Call a physician and let him be aware that this is what's happening. Okay, that is one time. Most of the time I tell you, I want you to handle the situation as a nurse, but when you've given a patient 3 nitroglycerins and it has not helped the situation, has not helped his pain, that is when we've got to go get some help. Okay? Obviously, there's something going on that nitroglycerin is not helping. Okay? So that's just a med that you're going to see a lot. The buccal medications you really just don't see that much anymore. But it is different. It is in the side of the jaw, not under the tongue. Okay? You just don't see that anymore. Okay? But Board said something about it in one of the books I was looking at, so I just wanted to let you be familiar with that and what it means to actually put it in the side of your jaw right here. There are topical routes as well. One of the most common topical that you're going to see is going to be your inhalers. When you have a patient, do you know what I mean when I'm talking about inhalers? They are medications that we suck in through the respiratory tract. Okay? Patients who have asthma usually have inhalers. What I need you to know how to teach somebody how to give or how to adequately do an inhaler. One of the first things that you want to do, and it may work better if I would have brought some samples in here, but the inhalers have a little tube that are put into a mouthpiece. And how you get that to administer is you just push the little tube at the top, and then the mist will come out. When you teach someone how to do an inhaler, it's very important that you have them to take a deep breath and blow it all out before they inhale. Okay? So they need to go. Then when you put the inhaler up, there's a little mouthpiece. You put it on their mouth, and when they are inhaling, you are going to squirt. So it's all in one motion. So it's, they want to squirt and take a deep breath and get that in, and they want to hold it in for at least 5 seconds. Okay?
In the HESI reviews, that's what I thought, but it said that they were supposed to breathe in slowly. But every time I've seen it, it's always that quick to get it in. So I was a little bit confused when it was like, no, you want them to breathe in slowly to get it in.
I'm probably over-exaggerating a little bit when I'm going like this. Because most patients who need inhalers can't take that.
I never thought of it. I would think that was too.
Yeah, this one didn't have questions.
I haven't looked at it. A lot of things, when you start looking up inhalers, some patients may have more than one inhaler to be given at one time. You need to know that when you have a variety of inhalers to be given at one time, you need to know which one you need to give first. Okay? There are some that, and I know you may know this and you may not. If you had a variety, what classification would you think that you need to use on your patient first? Who said that? Woohoo! What does a bronchodilator do?
Dilates the bronchial.
So we can do what?
Get deeper breath and then next to
Bronchodilators, yes. Bronchodilators do what? Open everything up. So if I give something before I give the bronchodilator, everything may not be opened up, so I may not get the biggest effect from that other inhaler. So you want to give that bronchodilator inhaler first, wait a couple minutes. I think 3 to 5 is what you're trying to remember what your book said. 3 to 5 minutes, and then administer the other ones in the order of what they need to be given. There are also a lot of inhalers that can cause thrush. Do you know what thrush is? It's a fungal infection in the mouth. So it is vital to know when you give a medication, an inhaler, that could, a side effect be thrush, what are you going to do for your patient? After you administer that inhaler, let them take good deep breaths and get that inhaler in their lungs. You're going to have them do what? They're going to swish their mouth out. Okay, so you want to make sure that you get that mouth clean so that medication is not, I don't want it in their mouth, do I? Where do I want it? I want want to go to the lungs. That medicine doesn't need to be sitting right there in their mouth. So you need to make sure that they swish their mouth out after they take certain inhalers. All right. Just through those. Another route that you will see is transdermal. Have you ever heard of transdermal? Okay. That is a medication a lot of people are seeing, we're seeing a lot now, is our smokers coming in and they can't smoke, so they're ordering them a nicotine patch. Okay? You will also see nitroglycerin patches as well. There are several things that you need to remember when you administer a transdermal patch. One of the first things you need to do is you need to make sure that the old one is off. Okay? These medicines come and they're supposed to be delivered over a 24-hour period. So if it was put on at 9 o'clock yesterday morning, it's supposed to come off at 9 o'clock this morning. So they still have another one on. You need to take it off before you put the new one on.
This past weekend, it wasn't my patient, it was another patient. I was listening to some of the reports because my person had gone home early. And they had a nitroglycerin patch. And so when the nurses were talking, and she said, well, there's no order to remove the old patch, just to put a new one every 8 hours. So she said they called the doctor because it wasn't in the orders to remove the old one. Really? Yeah. And so that was interesting.
Was it going to be like 20 patches on them?
And also they showed me the
So
orders.
let's leave all the patches on.
Yeah, but it was on the orders. It just showed apply a new patch every 8 hours. You know, it said remove it. So they called the doctor.
It tells you to remove
That's
it.
common.
Right? I would think that they just check.
But okay, let's look at it a different way.
They were on the orders.
They were following orders.
They showed you the form.
That was not a clear order.
That was not a clear order, so I see why
They did the right thing, really.
yeah, because she didn't really and anytime we look at it now and think, oh God, that was crazy. But I admire the nurse by saying, you know what? You don't have clear instructions here. You need to give me exactly what you want. So there's two ways to look at it. Yeah, I'll probably say, come here, take the thing off. But, you know, I got to make sure, because as a nurse, I'm responsible for that nurse, not for that patient. I got to make sure that I understand every order, don't I? So I admire her for saying, you know what? Explain yourself. Oh, I like that. You know, we can do something. Okay, but anyway, so when we put this patch on, make sure that the other one comes off. The other thing that you got to remember is this medication is absorbed through the skin. So you need to put gloves on when you open up one of these transdermal patches. Because if you somehow got it on your fingers, and I know some of you have never experienced this, nitroglycerin patches. I've actually not had gloves on before and put it on the patient and I got it on my fingers. I immediately had a headache. Immediately. Because what happens with nitroglycerin? Yeah, it was like, boom! Everything just went. Opened up just as pretty as you please, that little tiny bit, and it was just, bam, I got a headache. I mean, immediately. So, don't chance it. Go ahead and put your gloves on. Protect yourself from getting any of that medication. Now, if you smokers have got that, you know, you can't smoke in clinical. So if you've got a patient who's got a nicotine, you might want to touch that. Nicotine for you. Just picking. So anyway, put your gloves on. The other thing is when you take that patch out of the container, anything you take out, you know you got to scan, those of you at Northeast. So don't tear it somewhere that's going to mess up the scan. But when you tear it and pull it out, you need to actually write on the patch the date and the time and your initials to when you put that on. So when I come in and see that assessment, or I assess my patient, I can look and see when was the last, if this is the last time they put this patch on. What I will tell you is please don't put the patch on the patient and then write. Don't write on your patient. You got your gloves on, pull it out of the container, write the date, the time, and your initials on it. So when you get ready to administer it to the patient, you're not writing on it. Okay? So those are just little tidbits that's going to help you when you're given some of these medications. Any questions? Eye drops. You need to make sure when you administer eye drops that you want to get it in the conjunctiva. Okay? So you always put gloves on. Okay, always put gloves on when you're administering. When you pull that conjunctiva, have the patient look up, drop the drop in the conjunctiva. When they close their eyes, you need to take your finger and put it in the middle or in the inside canthus of their eyes. Okay? And put a little bit of pressure there. Not a whole lot of pressure, just put a little bit of pressure there. Why do you think I'm having them put pressure right there?
Because that's
So
what
it doesn't go into the
absorption. That's where the drop comes out.
So it doesn't go into the.
Think about absorption. Where do I want this to go into? The eye. If I go down through here, it can go and be into the sinus cavity, and it can become systemic, meaning it can get in the bloodstream. Is that correct route? No. The correct route was to give it through the eyes. So if pull that conjunctiva out, have the patient look at, drop it, have them close their eyes and put just a little bit of pressure here for about 5 to 10 seconds. It causes the medication to be absorbed in the correct way, so it's not becoming systemic. Eardrops. The biggest thing that you need to remember in eardrops, of course, have the patient on the side with the affected ear up. But this is the most important thing. With adults, with eardrops, you need to pull up and back. Okay? Up and back. With adults, children, you pull down and back. Why? The way their ear canal is shaped. You know, most children get lots of ear infections. And a lot of times when we're administering the medication, it's not administered the correct way, so it's not actually getting, excuse me, not actually getting in their canal. It's running out. If we pull up and back, it's not going to get into the correct place. Okay? So with adults, it's up and back. Children is down and back. Okay? All right. Let me get a swab. A cup of different injections. Things that you've got to memorize or know with these injections is with an intradermal, you need to use what size gauge? 26 to 27. What length? 5/8 3/8 to 5/8. So you're going to be responsible for when I say go get the correct instruments or the correct equipment to give an intradermal. Guess what? We sort of cheat a little bit with that because we have a syringe that is called a TB syringe. Isn't that nice? So we really don't have to, we have to know that this is the appropriate gauge and length. But if I'm going to give a TB injection, which is the only thing I have ever given for intradermal, you can just go and on the little package it says tuberculin. So you're going to know that's a syringe that you need. And when we practice on Tuesday, you're going to see this with your packages. They're going to have a TB syringe. All right, subcutaneous. Oh, I did it right here. What gauge? 23 to 25. Length. 3/8 to 5/8. Tell me your sites for a sub-Q injection.
Deltoid? I mean, no, I'm sorry. Johnson?
Deltoid is a what? Alright, so here is a sub-Q injection. It's on the outer aspect of the arm. Where else can I give it? I can give it the tops of the thighs. I need to break the, what do I put here? Hand breath. Divide this in the top into 3s, and I'm going to go in the middle. Where else?
Lower back.
Go on my little love handles. What about here?
2 inches away from the
My abdomen, I need to stay away from the belly button at least 1 to 2 inches. Y'all did study. Wonderful. No, there it is. All right. Intramuscular. I need a, what gauge? 20 to 23. Length, 1 to 1.5. What degree do I put it in?
90.
Sub-Q, what degree do I use with that? 45 or 90. I can do either one. What's going to make me make the decision? The size of the tissue, where I'm going. If I can pitch up an inch, I'm going to use 45. If I pitch up 2 inches, I can use a 90. Woo! All right, sites for intramuscular. Deltoid. How am I going to find deltoid?
2.
Find the little notch. 2 to 3 finger breaths. And this little triangle right there. How much medication am I going to give? 1 million. No more than 1. No more than 1. Right. All right. Where else? Vastus lateralis. Where is that at? Outside of the thigh, and I'm going to divide hand breath, outside. Do it into 3 different quadrants right there in the middle. All right, and this is the big one. Ventrogluteal. I'm going to find what first? The greater trochanter. I'm going to put my palm on the greater trochanter. Where does my thumb go? Towards the groin, right? I would say something with 3. Towards the groin. Where is this finger? Posterior iliac crest. I'm going to put it on there. Then I'm going to do what to my fingers? I'm going to spread and make a V, and I'm going right there. God, I'm impressed.
It says not to do that to a child under 1, but why is that?
Right, because their sciatic nerve has not been, it's not fully developed yet. You always give an IM or you never give an IM to 1 years and younger in the ventrogluteal. Never. Never, never. You always do it in the thighs. But you got to think about that too. It seems cruel to do it in the leg, but what do we want people to do after they've gotten injections? They want to move, don't we? Want them to move, because if they move more, the soreness is not going to be there and the medication is absorbed. So most 1-year-olds are out bebopping around and ready to go, so they can get the muscle working and they absorb the medication a whole lot better. Never going to use the dorsogluteal anymore. I showed you the deltoid. There's the ventrogluteal. All right, I'll let you take a 15-minute break. It's still intermuscular, but it is a different, it's the same, finding the same site, but it's a different way of administering it. Okay, so the site is still the same thing. It's the ventrogluteal, but it's called a Z-track. And what happens with that is any medication that is very damaging to the tissue. For example, iron. When you have to give an iron injection, it is very, very damaging to the skin and the tissue. It actually can kill tissue very quickly. So when I know that I have to give an iron injection, I know that I'm going to have to make that nursing judgment call to give it Z-track. And what happens with Z-track is when you find the ventrogluteal, and it's very difficult, and we'll practice this on when you're actually holding someone or got somebody in front of you, to show you how to hold the skin, because you're going to have to use both hands, okay? When you find the ventrogluteal, you're going to actually have to displace the skin over to the side, okay? And there again, when we practice on Tuesday, it'll make a little bit more sense to you. The biggest thing that you've got to remember is when you displace that skin, you've got to keep the skin displaced while you inject, aspirate, inject the medication. And when you inject the medication, you hold that there for 10 seconds. You want to make sure that that medication gets all the way into the muscle. So when you hold it for 10 seconds with it displaced over to the side, when I pull out and let the skin goes back and traps the medication in the muscle. So it can't make a tunnel going out following the needle. Okay? So as you hold it for 10 seconds, you pull the needle out, and when the medicine's in the muscle here, this skin is going to definitely go back over where the medicine was, and it can't seep back out. Does that make any sense? It'll make sense more Tuesday. I just wanted to, Tuesday and Wednesday, I just want you to realize that Z-track is a different way to administer medication.
So that's the only place you use this after
The only place you use Z-track is the ventrogluteal. The only place. You would never, because you do not, that is the biggest muscle that we use, right, to give it intermuscular. I don't want to give a Z-track up here because most of the time the medication is damaging. That's not a big muscle, is it? So why do I want to put medicine in something that's not going to be big? Plus I can only give how much here? 1 cc. 9 times out of 10 the dosage is going to be greater than 1 cc. So that's why. Now, is the physician going to write Z-track?
No.
He's not going to write Z-track. That is a nursing judgment call. If I know, when I've read about my medication, and it says very damaging to the tissue, I can make that nursing judgment call and say, I'm going to give it Z-track as opposed to straight intradermal. I can make that call. It's still going in the muscle, correct? So am I still following the orders? Yes, because it's intradermal or intramuscular. But I know that it's going to be damaging to my patient, so I want to put it in another way where it's trapped down in that muscle and it stays in that muscle so it can be absorbed correctly and not damage all the tissue coming out. Okay, does that make sense? All right. Huh? We are going to aspirate, but I'm going to... Huh? You aspirate IM. Yes. Yeah, and we'll learn more about aspiration when we practice. Okay? All right, I'm not going into a lot of IV medicine or IV routes right now because we're going to do more IVs next semester. You just know that there are intravenous is how we administer some. And I went ahead and put it up there, but I don't want to go into that right now. All right, we looked at, and we talked about this a little bit. When you give medications to children, you're going to have to adapt some of the ways that we administer it. For instance, one of the biggest things we were talking about a while ago is intramuscular. I don't want to give it in the ventrogluteal if they're a year or younger. Okay? Can't give it to them. I want to use the vastus lateralis. Remember we talked about when we have children, how do we base the dosage? On weight. It is a weight-based. A lot of times when you've got to give PO medications, obviously that 1-year-old cannot swallow a pill. So their medications are going to be coming in liquid form. The best way to give an oral liquid form to a baby is to put it in a little syringe. Actually draw it up in a syringe, and when you put it in their mouth, sometimes they'll want to go, you put it right here and they'll suck on it, but if that doesn't work, if you pinch the little cheeks like this and stick the syringe right there in the corner of their cheek and squirt, then after you're doing this and this don't work, we should usually let it go like this and we'll be able to swallow. Okay? There's all kinds of little tricks you might learn from doing pediatrics and giving pediatric medicine. We have to make it fun. We have to say, woohoo, this is candy, you know, that kind of stuff with them. So we have to do all kinds of tricks, and you'll learn those tricks when you get to pediatrics with Miss Ward. Never tell them it's candy. I wonder why y'all was chuckling. I was like, I must have said something about that. But notice that was a toddler. That other one was the 1-year-old. She don't know. Right? You tell them. They don't know. One of the biggest things with toddlers is they're full of themselves, and they like to get in places that they have no business getting into. So education of parents is very important. Make sure they know to store the medication without their reach. If they were like me when I was growing up, I would climb and find it. I love that little cherry stuff. When my mother would hide the Tylenol, and I thought it was so much fun to have that cherry stuff. Or the bubblegum flavor, that kind of stuff. So, and you're right, don't really tell them it's candy when they're this age. Probably just you can say, if you take this, I'll get you some candy. That may work a little bit more. You should always educate parents of toddlers on having poison control numbers readily available in case they are full of themselves and go drink a whole bottle of Tylenol. Okay? Or any other medication. It is vital that they have that number right there, because there's some medications that they need to induce vomiting with and some they don't. So whatever the child has taken in, we need to make sure that they call them and let them know and talk to poison control, and they can tell them they need to vomit or not. Okay? All right, preschool, they usually do pretty good with it. Usually tell us, you know, if we just tell them what we're doing, they're pretty compliant. We've talked about elderly considerations. I'm going. Medication errors. I want to get through the. I know I'm going fairly quickly, but this Beaver is making copies for me, so I'm hoping I can get through this real quick so we can start some of the meds calculations. She's going to see if she can do that for me. Medication errors. There should be no reason why we have medication errors, but you know what? We're human, and they happen. But you are totally responsible for that patient and the medication. Okay? Totally responsible. This is just a list of the things that we may have cause medication errors. I'm not going to go through step by step, but I want to tell you that it is vital that when you do make a medication error, you have got to own up to it. Okay? There are some things when we have a medication error, there are some things that we can give the patient that may be able to reverse the effects of the medication that we just gave them. Okay? So I know that you don't want to say, oh my gosh, I made a mistake, but in this situation, you have got to admit up to it and report any. Are you going to get written up? Yes. But the thing of it is, I have to have it documented because I need to know if anything else needs to be done for that patient. And of course, this is why the seniors call me law. Because I put this little thing up here. Under the law, all legal laws, nurses are responsible for their own actions. So if a physician writes an order that the dosage range is way out of whack, and you go and administer it, who's responsible? You and the physician. But you, because you gave it. Why is it important for you to know, when I ask you, is this dosage range within normal limits? You've got to know these things because you can overdose someone very quickly. Potassium is the worst drug that you can kill somebody with. It is vital that you know what your patient's potassium level is before you ever administer any potassium. Okay? My ADD is kicking in. Others? Me? Yeah. No. All right. Finish this little slide. All right, I do want to tell you that I just put up that with medication classification. Okay? What I'm going to do is I want to show you how, because it's basically you've got to memorize, and I usually tell y'all not to memorize things, but some of the medications you have got to just memorize what it is when I talk about an antibacterial. Okay? The things that what I've done with each one of these classifications is I have listed the classification. If there is a side classification, I have listed this. So at the very, very top is antibacterial. Okay? Aminoglycosides. That is a type of an antibacterial. Okay? I have told you what in pretty simple terms, because I know when you read in your drug book, it is very difficult for you to actually know what they're talking about when it comes to actions. Okay? So if you take what I've said here for the action, go to your drug book and read through what they've said as well for the action of this type of medication, and see if it sort of clicks with you a little bit that way to help you better understand. These are the things that we're going to ask you when you have to give medications. So I've listed them, the action, side effects, adverse effects. I can tell you they're the most important ones I have pulled out for each classification. Okay? There are, I know you're probably, if you've even looked at your drug book and looked at all the side effects, there are hundreds of side effects for every drug, right? And we talked about this the other day, and we talked about nausea and vomiting and diarrheas with it's a side effect for every drug, okay? And you're going to say, oh my gosh, Ms. Walker, how in the world can I learn all the side effects of every drug? The way that you can help learn those is pull out the ones that are in red. Or if they're italicized or bolded or underlined, whatever drug source you're using, there's got to be a reason why that's in red. And there's got to be a reason why that's bolded. Because that is going to be the most dangerous things that can happen if I administer this medication to a patient. And of course I want to look for those kind of things, right? With aminoglycosides, we're going to see a headache. You know, that's pretty commonly seen with it. We may actually see a little fever or a rash. But what's really important and what I really want to look at is what is nephrotoxicity. That is kidney. There's poison in the kidney. There's something going on in the kidney. So what would I look for if I administered an aminoglycoside to a patient? What would I decrease urinary output? Lab values, which is BUN and creatinine. So don't I need to make sure that those things are working before I ever administer an aminoglycoside, right? Because I want to make sure that that's working good, because do I want to administer, if I've got somebody who's got a high BUN and a high creatinine, would this be a drug of choice? No. Because I know that could possibly cause this. This patient is already compromised. So how would you handle that situation? You know, and what would you say? Dr. Jones, I just wanted to inform you that so-and-so's BUN and creatinine is this. You have ordered this. I'm concerned about her renal function. Okay, am I saying to him, you crazy dog, we need to change this medicine? No. What am I giving him? I'm giving him information to help me help him base a decision on what he needs to do. Okay, I need to change this. Okay, maybe there's another medication. Do you still want him to have this? No. That's why you got to understand what's going on. What is ototoxicity? Ears. Hey, here. So when you did your assessment, don't you assess hearing? So you would have a baseline of how they're doing when you gave, and then if you noticed a difference in the next day, she can't hear me. Well, she's 104. You know, is it coming from the meds or is it coming from her age? But if you go in there and she hears you and you're talking and here's okay, and then 3 days later, you start noticing, well, you know, Miss Jones is just not listening. She's not hearing me like I thought she could. Then that's when I call, you know, this may be something coming from this drug. So you see why you got to constantly understand what's going on with this drug. Now, I always get ahead of myself, don't I? I don't need these things, do I? I just run my mouth. All right, so we talked about VU and creatinine. Another thing that you can see to help give me some evidence to prove some nephro kidney function is if I have protein in my urine. Have you ever heard anybody say they're spilling protein?
Yeah.
Okay. Spilling protein is also another thing I need to look at to make sure that I've got adequate kidney function. If I start, it is not normal to spill protein in your urine. How would I check to see a protein?
24 hours.
Is it easy way I can do that? I can do a urinalysis, but can I have them? Yeah, pee in a cup. If I'm peeing in a cup. But can I need something real quick.
Dipstick.
I can do a dipstick. Exactly. Do we have dipsticks on the floor? Yeah. Do we need an order for that?
No.
I can just go right in there, have my patient get the sample, stick that little dipstick in there, and I know exactly if they're spilling protein or not right then. Okay? Very, very. What disease process causes people to spill protein? Diabetes, exactly. They also spill what? Glucose. They also spill ketones. Exactly. So I got to make sure I don't want to wait sometimes on the urinalysis. Yeah, I'm going to send it down, but I'm going to go ahead and dip that stick in there, and I'm going to get a reading right before. Now, I'm going to use my analysis too. Don't get me wrong. But at least I got something. And if the physician's up there, or I want to call him and say, you know, I dipstick this, and this is what I found, I'll send you the results when I get the urinalysis back. So he's going to have a heads up of this is what we found in the dipstick. So he'll know that I'm probably going to call him back in just a little bit with the urinalysis. Hearing loss, dizziness, lightheadedness, fullness in the ears, ringing in the ears, those kind of things are also seen with those type of meds. Like I said, I'm not going through every one of these, but I have included things that you need to include when you're given these type of medications. These are the things that you need to monitor in that nursing interventions. Yeah. And it's assess, monitor, provide, inform, administer, and teach. So I've given you lots of things that you need to teach this patient when they're on this type of medication. All right, now, for testing purposes, there is no way possible that I could ever give you every amino glycoside for you to know. So what I've done with each one of these classifications that I want you to know, I have given you 2 to 3 examples, I think, on each one of them. Remember, I told you I'd always give you the trade name and the generic name, so you'll have both of them. So if you have a better time learning the trade names than the generic names, you'll have them both. Okay? I would try to get you to start learning both. Okay? But as you're beginning, if you got one or the other you can learn better, then stick with that. But I've given you just 2 in your books. In that, what is that book called? Pharmacology book. It is very difficult to follow. It gives you like 20,000 meds for you to remember. I'm not going to do that. That is just not feasible at this point in your progression, okay, or in the program. So I've given you just a list. And I know some people had emailed me and said, Ms. Walker, what reading from the pharmacology? I don't want you to go into the pharmacology book yet. Okay? I want you to use this for studying purposes, because this is the beginning of understanding slowly what do you need to know. What is the action? What is actually happening in the body? What do I want to see my patient, it happen in my patient? Okay? What kind of adverse effects? What kind of side effects? Is the dosage okay? What am I looking for when I go in and I give this patient this medication? What am I going to be looking for as a result of me giving him that? Okay? So these are the ones that I want you to know. I do want to just sort of slide through. We can slide through every one of them. And just, is there any terms that you don't understand and you're not familiar with? I think I went through AST and ALT labs. What is that testing for? Liver function test. Potassium. What's the normal range for potassium? 3.5 to 5.5. You have got to start memorizing these. 3.5 to 5.5. Vital information. Vital, vital, vital. Beer and creatinine. We've talked about that. Do you know what PCN is? Penicillin. Exactly. Anything on this one that you're not sure? Did you get everybody fixed? Did you notice on a lot of these antibacterials, one of the biggest things that I've put on there as far as teaching wise is to take the whole course. How many people start taking meds, they feel better, I don't want to take it anymore. We have got to do some teaching with these patients. I am just as guilty as anybody else. You've got to take the whole course, because what's going to happen is I feel better after 3 days, and I have a 7-day course of medicine, and I stop. What's going to happen? I'm going to get sick again, aren't I? Because there's a reason why he gave you X amount of days, because it's going to take that many days for us to kill that bacteria or get you better. Okay? It is vital that they take the whole dosage. Oh, I gave you 5 on this one. Dang. Sorry. Now, the pages that I did list on here for you is the the pharmacology book. So if you want to look in it, you're more than welcome if you want a source. But I can tell you, there's probably 20 more medications listed there. But these are the most common ones that you're going to see. Yes, I'm hot. Thank you. I ain't made hot, Mama. Oh, no wonder it's hot. Sorry. Let me open that. There. Did you just have a hot flash?
No, like, me and Jason been talking about it for 30 minutes.
Why are you talking in class?
Talking about it. I don't know what you're doing.
Why are you talking in class?
It was in between your sentences.
It is warmer back here than it is.
It's warm in here.
Yeah, you do not have to worry about, because it's going to have a whole list of 20 more of these meds. These are the most common ones that you're going to see in this classification. Penicillins, anything here? You know what STDs are? You know what UTIs are? I'm gonna keep clicking until y'all tell me. Nausea and vomiting. Nausea and vomiting.
This one.
Uh-huh.
This one has the yogurt. The other ones did not. To replace normal flora.
Uh-huh.
Is there a specific reason that it's only listed with penicillin and not the others?
Let me find. Is penicillin, that is more commonly causing diarrhea than the other ones. And when you want to replace that normal flora is when they start having diarrhea. If they are not having diarrhea with any of the antibiotics, then we don't need to really replace, is when they start having that diarrhea. That's when we need to worry about that.
I just didn't know if there was a specific reason why it was only under penicillin and not the others.
It's just most commonly seen with that. Diarrhea makes the majority of people have diarrhea. So go ahead and, one of the things that you would teach them is you wouldn't have to start them off that way. Just say, you know, one of the side effects is having diarrhea with this. If you notice that, try to include some yogurt with your diet to help replace all that.
Do you think that would be because we teach them to take it on an empty stomach? So it might have said.
Yeah, that probably is one of the major reasons, is to tell them to take it on an empty stomach. But personally, any antibiotics, even though the book sometimes says have them take it on an empty stomach, with antibiotics, I try to say either you take it and then you eat right now, or you eat and then you take it, one or the other. Or take it with food, because 9 times out of 10 people are going to get nauseated and vomit and have diarrhea if they don't have something on their stomach when they take antibiotics.
Bless you.
All right, and those are the 2 other ones, and there again, those are the page numbers that has more meds on it. Oh, Lord have mercy. Why does this do this to me every time? Every time. Every time. Right back in here. Oh, did I click it? All right, those are the most common ones there. Anticoagulant. Y'all tell me what toes turn purple. Decreased perfusion. Decreased perfusion. Look, discoloration caused by decreased perfusion. Thank y'all so much. I appreciate it. Jaundice. What's jaundice? Yellow. Where's the first place you look to see if somebody's jaundice? Sclera. Can you pinch their nose?
No.
Yeah. Not pinch it, just push their nose sometimes. Who's the most common people that get jaundice? Newborns. Why? Immature liver. Immature liver. What kind of activity do you think a baby would have if they're jaundiced? Very lethargic. Very lethargic. Y'all are pretty smart. I'm liking this. All right. Jennifer had a question about PT and IR and then PTT. Okay, so they're two different things. Okay. Was that your question?
Yes, I was trying to figure out.
PT is prothrombin time. PTT is partial thermoplasm time. Partial thromboplasm time. There's two different kinds, PTT and PT. And I'm not saying it right.
Oh, no, there's an APT.
Yeah, yeah. But don't worry about APTT. Just worry about PTT, just partial thromboplastin. Plastin. I can see the word, I just can't say it. Partial thromboplastin. Right. Right. This is PTT. PT is prothrombin time. Don't you write that? I don't know if I spelled that right or not. I know that's spelled wrong. It's
Wrong. You missed the R.
there you go. Prothrombin time.
INR is a read.
And this is PT. INR is international ratio. The IN stands for international ratio. Okay? These three all work on clotting factors. That is the biggest thing that they're looking for. When your patients are on any anticoagulant, for instance, a PO anticoagulant like Coumadin is the most common one, what lab value do I need to monitor? PT and INR. If my patient is on heparin, which is a IV or a sub-Q injection, what labs do I need to watch with those? PTT and INR. Did that make the question? Okay. You have got to know with heparin is PTT, with Coumadin is PT. Okay? Both of them are INR. I want to say that INR is 1 to 3, but don't quote me on that. What they're looking for with PT and PTT is how does the blood clot? Is it 2 to 3? 1 to 3. I don't care. 2 to 3. Thank you. We're looking at clotting factors because what does an anticoagulant do? It thins the blood and doesn't want it to clot up. But I still have to have clotting factors, correct? Because if I have a bleed or if I get nicked or cut some way, if I'm getting too much Coumadin, it's going to make my PT be out of whack, so that means that I might bleed to death. But then if it's not enough, I could do what? I can throw a clot, couldn't I? Okay? So why is it so important that I keep this within therapeutic range? I either can bleed to death or throw a clot and die.
Best of both.
Okay, so do I want my patient to do any one of those things? No. I've got to get them in that normal range. What is something you've got to make sure you teach them when they go home? If they're on Coumadin. Don't get cut. Huh? Take it as it's prescribed. Make sure you keep those appointments for your blood to be taken. And they've got to be checked every week. Okay?
It says for bruising.
Don't eat. You need potassium, but don't eat a lot of green vegetables. Okay? What, as far as their care?
Safety.
Safety. What do we always want to do? Shave. Do we want them to use a razor? No. We don't want them to use a razor. So when you're in the hospital setting and the CNA turns around and says, Haley, can you go shave Joy? Sure I can. The one thing that you want to find out is he on any anticoagulants? You can't shave them? No, they can't. No, they use electric razors. Use electric razors, yes. Yes, they can shave, but they need to use electric razors, not straight edge. Okay? But don't you want to make sure that you know that patient, because most of the time we go in and shave somebody, we just get a razor, don't we? Just go at it. Okay? But if I've got a patient on anticoagulant, I don't want to do that. Okay? So what's going to happen when your patient starts bleeding out? Miss Walker!
Hold pressure and cold.
Hold pressure, exactly. Use your big mouth. You want to hold pressure to wherever it is. Call for help. Miss Walker! Call for help. But what do you think, what would you think that the physician might order? An antidote, which is vitamin K. What do you think we give newborns when they're born? Vitamin K. Why? They don't have that clotting factor yet, do they? Starting to work. So they could actually bleed. Where do you think they would bleed first? They bleed to the brain first. So it is vital that you give that newborn, as soon as they're born, vitamin K. Okay. God, y'all pretty smart. I'm like really impressed here. Huh? Somebody's been studying. Woohoo! All right, I'm going to flip through these and y'all tell me anything else. Soft toothbrush is another thing. The antidote that reverses the action of heparin is, y'all know that from that little activity we did. I'm going to keep going till y'all tell me. Go ahead. Go ahead. You think I want you to know protamine sulfate? Huh?
What is blood?
Gracious.
That means any, not just one, like a white blood cell or a red blood cell or hemoglobin hematocrit. It could be any discrepancy in. Most of the time, like when you give something that would decrease the hemoglobin or something that would decrease a hematocrit, that would be the only two blood problems that they would affect. This means that there could be anything wrong. There could be something wrong with the white blood cells. There could be something wrong with the neutrophils. There could be some, I can't give you a specific, there could be any abnormality with the labs. You got to watch all their CBC. Because it can affect the white blood cells, it can affect the red blood cells, it can affect the hemoglobin, it can affect the hematocrit. So all of them are going to be looked at, not just one or two. That makes sense? He asks, what is the blood any discrepancy in any blood values? Where's it at? It's an anticoagulant.
Antiplatelet.
Side effect.
Any discrepancy, so it's not just most. We talked about the patch and doing that.
What's the difference between like an anticoagulant and an antiplatelet? Are they both like?
They're both working on the clotting factors, but the coagulant more is going to be looking at the clotting factors. Can I clot, can I not? I want to thin it out. Platelets just look at platelets. Because there's discrepancies in my volume as well. With the anticoagulant, I look at the volume as well, but the antiplatelet is specifically for clot. Blood volume and the clotting factors. And there's different clotting factors that you look at with each one of them. The anticoagulant, yeah, I want to see that I've got a good volume and clotting factors with the PT and the PPT. Platelets, I want to look at platelets with they clot. And the time of it is a big thing. Anticoagulants, you want to look at the time that it's clotted, not just the fact that it does clot. And I think that's worded that way. If you look at anticoagulants, you're looking at the time factor of the clotting, but an antiplatelet, you're looking at the clotting factor itself. Does that make sense? Is anybody overwhelmed or not? You are watching the bleed time as well, but you want to make sure that they can clot too. You watch the PT and PTT. Any kind of bleeding issues that you can have, you're always going to watch the PT, PTT, or INR. Always.
The side effects on nitrate is postural hypotension. Is that the same as that changing?
Yes. Postural hypotension is when you have the standing, sitting, and lying issues with it. With the blood pressures, there's a difference, and it's going when they stand up, the blood pressure is going to go down. Okay.
It says adverse effects, hypertension. What is heart block?
What are you under?
Adverse effects.
I don't know if I really want to go with the heart line right now. There are, you can have an AV block, you can have an SA block, you can have all these different blocks. And it's talking about the conduction of it, because there's a conduction between the SD and all that. There's something that's breaking that connection and that conduction. Huh? Broken circuit. Perfect. Perfect.
Now, would that potentially cause atrial fib or any type of fib, or would that just
Yeah, you,
actually...
as a nurse, you can't say, and I probably should have put heart block on there, because as a nurse, you cannot say heart block. That is a medical diagnosis. How you would be able to assess that is through an arrhythmia or a dysrhythmia. Do you know the difference in those? Arrhythmias, it means that when I'm feeling it, the rhythm is not the same. So it's love dub, love dub, love dub, love dub, love dub, love dub, love dub. That would be, but I can't say AFib.
So
I can't say that. I have to say irregular heart rate.
Wouldn't that also
And
be
rhythm.
dysrhythmia?
Yes, it is a dysrhythmia as well.
What's the difference?
Arrhythmia means Y'all, this is too deep for y'all.
What if?
You want to do Christine? I know, but it's a little, you're gonna
So
have
would we
to-
just say dysrhythmic or?
I would prefer you not at this level that you're at right now. I wish you would just say irregular heartbeat and rate and rhythm. Okay, that is all that you need to know at this point in time, because you can never diagnose somebody in AFib or a flutter or well, hopefully you can do asystole. Okay, you know what that means? No heart rate. Okay, that's just a little bit deeper than what you really need to go right this moment. Okay, all right, anything else that you're not CHF, you know what that is? Congestive heart failure. I don't even know how far I got to go. Do I? What's ETOH?
Alcohol
Withdrawal. How am I doing as far as how much form I got? All right, why don't y'all just tell me which ones what you have a question about, and then I'll go.
Insulin.
That'll be 24. All right, so what are your questions about the meds? All right. So, what are you wanting? Ask me what you want me to.
I want you to tell me the whole thing about that.
All right, how insulin works.
Well, I mean, not how it works, but this whole thing.
Okay, so you know that there's going, with insulin, there's going to be short acting and long acting. Do y'all really need to take a couple minute break before we get into this? Because this is really intense. No? Okay. All right, so there are short acting and there are long acting insulins. Okay? When you give someone the insulin, you know what, we've talked a little bit about what happens in the body. But as you're monitoring this, and I told you the other day, these are the three things that you've got to know about insulins. I want to know that at 7 o'clock, I administered a dosage of Humulin to my patient. Okay, so I administered at 7 o'clock. I know within a half an hour to an hour, that is when my medicine's going to start working. Okay, so that's when it's going to start. I gave it to it at 7, so between 7:30 and 8, I should see a difference, or I should see my patient responding to the medication. That is going to be the time that I need to start monitoring them for the side effects that could be associated with me administering insulin. For example, what? Hypoglycemia. So what happens when a patient is hypoglycemic? They become diaphoretic, they get shaky, get disoriented, blurred vision, tachycardic, all these things. So you know when you go in there at that 30-minute to an hour window, that's when it possibly could start happening. So you want to start looking for those kinds of signs at that point. then you know without a shadow of a doubt that when we give that patient that insulin, so we're giving them the insulin, and 2 hours, it starts working in that 30 minutes to an hour, and then it sort of starts to level out a little bit. Then 2 hours, so at 9 o'clock, you're going to know that the peak of that medicine is going to start working right now. So they would be at risk to do what? Developing signs of hypoglycemia again. So it's not just give it to them, look at them 30 minutes and go. You're going to know that at that 2 to 4, there's a possibility that they could bottom their blood sugar out because that's what insulin does. So you got to watch them from that 2 to 4, that 9 to 11 time. And the good thing is that this takes effect 5 to 7 hours. So I know that when I give this medicine to this patient, he's going to be covered for 5 to 7 hours on this dosage. You know, when you give a pill, if you only give it 1 time a day, how long is he covered? 24 hours, right? But with this dosage, it's only going to last him 7 hours. So what could possibly happen after that 7 hours? My sugar could start going up again. So I only can't just watch my patient take him the pill or take whatever and go on. I got to look at the different times that this medicine's going to start working. So I got to also look at, do I just medicate a diabetic? There's lots of other things that happen with diabetics that I need to include in that, i.e.
What their diet is.
Right. What are they eating? Okay, because if they eat a bunch of sugar, what's going to happen? Is this gonna help? No. It's not gonna help. So in other words, at this peak from 2 to 4, and they ate 14 donuts, and I didn't know, I can say, okay, well this insulin started working at 2 to 4. I would expect my blood sugar to start being maintained from that 2 to 4 hours. But they ate 14 donuts. And that's gonna do what? Shoot it straight up. So you've got to watch them not only for hypo, but hyper. And you've got to look and see what they eat. How is what their diet help controlling it? What are other things that might affect a blood sugar? Exercise. What if my patient had to go to rehab and they rode the bike for 45 minutes? And I gave him insulin 3 hours ago. Would he be okay? Would he? Because the insulin's going to be working and the exercise is going to be working. So this is not just a drug that you can not look at other aspects of it. Is that what you wanted me to cover?
I think my main question was the regular mixture, where it was talking about how the peak is 5 to 10 hours, but the duration only lasts 6 to 8. I don't know if that was a typo or if I was just not understanding.
Okay, that is the same question that. So the regular, you know, is going to take a short acting. I'll get that. Okay. This is the problem that. Okay, MVH is going to be what? Long acting. So it's going to last at least 24 hours. Okay. This is the problem that lots of people are having. Don't quite get this right now. NPH and regular mixture, there is 70% long acting, 30% short acting. It is a mixture of that medicine. So that's why you see a difference in this. Because of the mixture of it, because there's more long acting than there is short acting, so you're going to have a longer peak. It's going to last, it's going to start going like this. And because of the NPA and the regular mixing together, you're going to see a different with this. It's going to start soon because that regular's in there. If it was only NPH, you wouldn't have started. But that 30% of regular is making it start working quickly. Then the peak of it is mostly the long acting. Okay? Now you're going to also see 75-25 is still the concept of 75% regular or NPH and 25 here. So it's going to end up being 100%. Just understand that you've got to know that this starts happening. And what I am more concerned about is the fact that you know that when I administer this at 7 o'clock in the morning, that there are 3 different time frames that I need to watch my patient because I have given them something. It's not just give it and leave them alone.
Like just basically know that monitoring whatever.
No, I want you to know when you administer a regular insulin, you're going to tell me that the onset is a half an hour to an hour, the peak is 2 to 4 hours, and the duration is 5 to 7. You've got to know those time frames.
Are you sure that's not 18 to 24 on the NPH?
Peak is outlasting the entire duration of it.
Yeah, I was gonna, that's, I don't
It is 18 to 24.
On the mix. It's 6 to 8.
On the duration.
It only lasts 8 hours, but the peak lasts 10. That's the harder.
I mean, how would you know what to do?
I'll look up and see what your book said, but I know that's,
Because I think,
I just typed that, and I'll make it right if it's wrong.
I think I marked it out.
Huh? Did I mark it out wrong?
For some reason.
Yeah, I'll look at it. I'll look at it and make sure that I've got it right, but I'm not a secretary. That's by all means, I am not a secretary. But I'll make that right. But you're right, I can see the duration being 24 hours. It may just, I missed that.
I don't understand why it's written NPH first since we draw with regular.
No, this is already mixed.
Okay.
This is already mixed, so you're not going to be drawing up 2 different things. We will be practicing drawing up 2 different things, but no. But yes, you've got to know the peak, the onset, and the duration of every one. Did I answer your question? There was somebody else that had a question back there, I think. Yeah, and that's probably my error. But I was going with your little book, so let me look at your book again and make sure that that's correct. If not, I'll send you a thing. All right. But I know it's 70-30. And it may have been my mistake. All right. Y'all want to stretch a minute? Oh, I know what you can do. All right, everybody up. One of the biggest things that people have trouble with is conversions from one system to another system. That is where generally you're going to have the biggest problem. So what I want to do first of all is not go there yet. I want to teach you how the different formulas that you can use when it comes to a medication of the same unit. Okay, so if we have the same unit, then, do you know what I mean by saying the same unit? Like milligrams to milligrams, okay? There are basically 3 different ways you can do drug calculations. There is a dose over half, which is called the simple formula, that's my favorite, and that's what I use. There is ratio and proportion, which is Miss Ward's favorite and where her expertise is. And then there is dimensional analysis, which is Miss Beaver's favorite. So I can tell you right now, if you know and choose to use dimensional analysis, I am not going to be the one that can help you. You're going to have to go to Miss Beaver. Okay, I can't get my little tiny brain around dimensional analysis. I think there's a lot of work that you don't need to do. But anyway, that's the 3 people. Dose over half is me. Ratio and proportion is Miss Ward. Dimensional analysis is Miss Beaver. Okay, so all you math whizzes, if you have trouble and you use dimensional analysis, you go to Miss Beaver because I can't help you. All right. So, with this little thing, I'm going to show you, if you look on the front page, there is a label of the medication there. You will always have an order, and then you have to figure out how does the medicine come. Okay? Now, some doctors may write, Coreg 6.25, and when you go to the drawer, it's going to be a Coreg 6.25 milligrams. Is there any calculation that needs to be done? You're just going to give one tablet. Okay, so there's no calculation. Now, we could make that simple like that, but there are times that they say they want this milligram and the pill comes in a different milligram. That is very common. Okay, so what you need to do on Monday when you get your orders and your medications, your medication orders, it's going to say this is what the doctor ordered. We always got to follow the order. So this is what Dr. Jones ordered. It's going to benefit me if I look to see how it comes. I cannot do a medication calculation without knowing how the medication comes. Meaning when I go to the Pyxis that we talked about the other day to get my medicine, and how am I going to get it out of there, and how many pills do I know I need to give until I go get that the day of Monday? Wouldn't you much rather do your calculations without me looking over your shoulder? Because some people, and I'm not being ugly, is they can't do 2 + 2 when I'm standing over going, okay, Deanna, hurry up. You know, and I don't want you to be like that. I want you to go on that Monday, get how the medication comes, go home and sit at the kitchen table and say, okay, this is my dosage, this is how it comes, and do your calculations without anybody bothering you. Because you're more apt to have it right then than having somebody come over you and look over your shoulder. Okay? So go on Mondays and see how it is done, or how it comes. All right, all All right, if you look at that first order, on there, co-reg, 6.25 milligrams BID. Now, when you look on the label, can anybody tell me how this medication comes? 12.5. So the order says 6.25, but it only comes in 12.5. Now, how many of you are saying, I can do that in my head? I don't want you to do it in your head. Okay? I want to see some type of formula that you're going to use. Now, the formula that I use is dose over half times quantity equals the med. I can do this if I have the same what? Unit. I have to have the same unit before I can do dose over half. I think it used another term. Supply over half. Whatever. I don't care what terms you use. I use dose over half. That makes me more, if I use supply, that I'm thinking that's what is supplied. That is not. The dosage that the doctor has ordered is what? 6.25 what? Milligram. And I can tell you right now, when you do your calculations, if you don't have your unit at the end, it is wrong. You can put 1 or 2, but I don't know what 1 or 2 you're talking about. Is it 1 or 2 milligrams? Is it 1 or 2 pills? Is it 1 or 2 capsules? Is it 1 or 2 milliliters? I don't know. I need you to tell me, okay? So, dosage is 6.25 milligrams, right? How does it come? What do I have available? 12.5 milligrams. Now, quantity. That comes 12.5 in what? 1. Who can work it out? 0.5. I just wrote it. It's tablets because it comes in tablets. So I'm going to give half a tablet. You just did a medication administration or calculation. Do I need to do ratio proportion? I am not doing dimensional analysis. I'm sorry, I just can't do it. There's a lot of things I can do, but I cannot do that.
So on our application,
10.
they all do just like that?
No. All right, let's do ratio proportion. All right, ratio proportion. I'm going to have 1 tablet per 12.5 milligrams, right? Is to, because I'm trying to figure out how much I need to give. So I'm going to solve for X, right? And then if I have, what's the order? 6.25, right? So this is to this, is that is to that. Okay? I hate to do this. Alright? So if I have, what you do is you cross multiply with ratio and proportion. Okay? We know without a shadow of a doubt that 12.5 milligram equals 1 tablet, correct? That's what I know. So I have to go with what I know to what I don't know. So I know that 1 tablet equals 12.5 milligrams, so I need to know what X is to 6.25 because this is what I got to give. Okay? So then I multiply 1 times 6.25. Oh, I don't want that there. Equals 12.5. Help me? X. Right? So I multiplied this one times that, and this 12.5 times this. Okay? Cross multiply. Now what I do to one side, I gotta do to the other. Right? So now I've got 6.25 milligrams over 12.5 milligrams equals 12.5 milligrams over 12.5 milligrams X. Now what do I gotta do?
Divide.
I gotta cross out, don't I?
Yeah.
That equals 1, or that's gonna be 1x equals 0.5. That's ratio and proportion. Right. But you have to, there's some people that like ratio and proportion.
That's algebra.
Okay? Now dimensional analysis will take me a whole nother line. And it actually shows you how to do dimensional analysis, but I ain't doing it. I refuse. Okay? So, you can either do it this way or this way.
So in this one, the dose would be what the order is, and would be what it's on.
Dose is what the doctor ordered. Have is what you have available times quantity. All right, you want me to leave that up? Ratio and proportion?
Yeah.
Okay. All right, so now let's look. There's all these little instructions here that tells you exactly what you need to do. The thing I like about this handout that I gave you is it shows there's plenty of things to practice on, but it shows the formula method, it shows the ratio proportion method, and it also shows dimensional analysis. So it shows you each way to do everything that you need. Okay? All right, you want to try another one? Yeah. Let's look here. Zyprexa. It's on page 87. Zyprexa. Okay? So if I have dose over half, what's my order? 7.5 milligrams over what I have. What do I have? 5 milligrams. Do I need anything here? 1. Do I really need anything there? Because when you multiply something by 1, it's what? It's it. Okay? So dose over half, so I divide 5 into 7.5, which is 1. And move that little decimal up there. That is your dosage. You will give 1.5 tablets. Do you want to do ratio and proportion?
No. You're going to convert us all.
It's easy. Okay? I mean, it's very easy. The thing of it is what you've got to realize is you've got to get it to the unit, the same unit. When you have a different unit, it's when you're going to have a problem. Okay? Not a problem, but there needs to be something else to be done. Now, if this one, let's look at it this way. If my dosage is different from what I have on hand, which unit do I want to go to? What I have on hand, don't I? I can't believe y'all just said that right. Because most people look at me and go, what the doctor ordered. But I'm still given what the doctor ordered, right? But if I have it different, or if I have it available and I don't have milligrams, I can convert. So you have got to look to see, do I need to convert first? Then, once I get the same unit, do dose over half times quantity. Simple as that. See why people stress about this? Not stressed about, is it? Nothing to stress about. Alright, we hadn't seen the conversion. I'm not going to go to conversion yet. I want you to get normal first. Not drips. Okay. No drips.
Just this.
We're doing oral, liquid, sub-Q, and IV. But you can do every calculation using this formula. No IV stuff. No IV stuff. Now there might be some practice questions in here on IV, but it's just asking you how much medicine you would give. So it would be the same formula. Yes.
How do you know what the quantity is?
That's what I'm going to do right now. Okay? Look on page 96. This is actually going to do two different things, which I'm going to write them up here. This is actually going to do a conversion. Okay, and I'm going to show you an easy way to do the conversion. Okay? Alright, what's my doctor's order? Lanoxin elixir, 500 microgram. Oops. It's a funky C. Micrograms. Okay, he wants it only to give one time. How does this come? 0.125 milligrams per 2.5 milliliters. What's the first thing I have to do? I have to convert. Which one is the biggest? Well, let me just say, where's my decimal in this one? Right here, right? Okay. So, which one's the biggest? Milligram's the biggest. So, where do I need to take my decimal?
To the last 3.3 place.
Because this is small, this is bigger than this. Okay? So I need to move my decimal how many places? 1, 2, 3. Okay? So now I have 0.5 what? Milligrams. Is that my dose? Is that what the doctor wants?
Yes.
Okay? Alright, let me put this up here. So I want 0.5 milligrams, which is the same as 500 micrograms, what he ordered, because I did a conversion, right? So now I have my dose. Now it is 0.125 what? Milligrams
times
2.5.
2.5 milliliters. So dose over half times quantity. You may work it out.
Do you have to turn it into milliliters since the package says milligrams and milliliters on
No, that is milligrams per milliliters. So in 2.5 milliliters, there is 0.125 milligrams.
Right. What I wonder is because it works out to 2 dosages, right? Oh, it's not.
Divide this into this first.
Oh, right.
This into this first. And what do you get? 4 times 2.5 equals 10. So all you would do would be pour up 10 milliliters and you have 500 micrograms in 10 mLs. I had 0.125 in how much? 2.5. Now I have 500 micrograms or 0.5 milligrams in 10 mLs. Got it? No. Didn't I tell you you're going to have trouble converting?
Now, how did you
Dose over half is not a problem, right? It's perfect.
Explain the answer, like, the answer to the problem. How would you say that? You said it would be 0.5 milligrams per 10 ml.
Yes. 0.5 milligrams per 10 ml or 500 micrograms in 10 mLs. Okay?
Is that how, when we're giving this out, then are you have to pour it from that package into the little
Yes.
So you said it would be 0.5 milligrams per 10
No, honey, you got the milliliters, not, the 4 has nothing to do with it. Because the
How many milliliters? I think I'm going to stop at 10. I have 10. Okay, so you do the portions. These bottoms have to line up. The side by sides, they gotta be matching.
You don't look at it that way.
Okay, that's what I was trying to understand.
Yeah, you gotta figure out how many milliliters you're given. Don't look at this and say, well, I know this is 2.5 milliliters, I'm gonna get 4 of them.
Is when you do
Right?
Okay, I was looking at it like
This is what you
this
start
ends
out
up
with.
being 1 dose.
This
Or,
is what
never mind, it's okay.
this is
I understand.
the whole thing.
You got to go,
This is how it's broken
we're gonna
down.
pour it into one thing together.
And the thing to remember that if you've got milligrams on this side at the bottom, you're gonna have milligrams on this side. So then you can just take whatever it's giving you. I don't know. You just gotta figure out what's better for you.
Oh, that's fine. Yeah, 10.0. Right.
I didn't rewrite it that way.
Yeah.